Hello and welcome to the National Dialogues on Behavioral Health Conference. This is session 4, Disparities, Children, Adolescents, Race, Ethnicity, and Gender. My name is Jessica Flick, and I'd like to introduce your host for today, Vijay Ganju, the president of the National Dialogues on Behavioral Health. Vijay, over to you.
Thanks, Jessica. Well, hello, everyone, and welcome back to many of you. I know this is the 4th session, and we've now been doing this for the last 3 weeks. And so, as Jessica said, my name is Vijay Ganju, and this year I am the president of National Dialogues on Behavioral Health. And so, on behalf of the executive committee, it's once again my pleasure to welcome you all to this session. As you know, this year's conference is titled Behavioral Health in the 21st Century, Fast Forward After the Pandemic. And, as you know, the theme of the conference is quite simple, as I've stated before. It's a lot of very good things were going on in behavioral health in different areas before COVID hit. Then COVID happened and the field had to scramble to adjust to the new realities. And we learned a lot through that process. And so the whole idea of this conference is, what have we learned? What can we build on to define the future in behavioral health from different perspectives, in different service areas, for different populations? And so today's session is really focused on looking at this whole issue of what good was happening for the populations that we're going to be addressing, children and adolescents, and minority ethnicity and racial disparities. What were we doing to address that? And then what happened to these populations during COVID? And more importantly, how are we going to take all this knowledge, some of it old, some of it new, to essentially drive what happens in the future? So that's really the thrust of all this. So as in the prior sessions, I am just going to do a quick overview. Jessica is going to be sharing some of my few slides, and then I'm going to be turning it over to Mary Smith, who is right now going to be moderating the session, and in that role, she'll be introducing the speakers and then sort of managing the entire session, including the questions and answers. Mary Smith is a member of the National Dialogues on Behavioral Health Executive Committee. She's the past president of National Dialogues as well. And previously, she was the director of planning, research, and evaluation at the Illinois Department of Mental Health and Substance Abuse. So, Jessica, my slides, please. I think we can go to the next slide. I think, I'm not going to dwell on this because I've mentioned this a lot, but the point is that National Dialogues on Behavioral Health is the oldest annual conference on behavioral health in the United States. This year, it's our 62nd annual conference. And I think the way everybody talks about it is that, and I'm just quoting people, so it's not my description, but it is sort of a jewel of a behavioral health conference. And part of the idea is that it's a small conference, but we have a lot of discussion and dialogue, especially in terms of implementation. And topics vary over the years, but it is a gem of a conference, even though, as president, I say so myself. Next slide, please. And so I'm not going to dwell on this. I've shown you the slide before, but it gives you a kind of range of topics. We really try to hit cutting edge topics, areas that the field is trying to grapple with, whether it's workforce or value or outcomes or the issues of resilience or prevention, criminalization. And those have been some of the topics that we've addressed in the past. Next slide, please. And when we have the in-person conference. It's usually in New Orleans, but we also have a pre-conference where before the actual conference starts, we actually spend an entire day on a specific topic, and we bring in speakers and have very in-depth discussions in different areas. And again, these shows you the kinds of topics we've covered in the past: school mental health, artificial intelligence, how what's happened over the last 10 years in behavioral health, and again, issues like mindfulness and alternative medicine and how it impacts the field. Next slide, please, Jessica. And so once again, part of the mechanism by which we have this conference is that we have we have an executive committee, and I'm not going to read everybody's name, but they're all listed. Many of them are long serving. It's an entirely voluntary organization. Nobody really sort of earns anything from being parts of national dialogues on behavioral health. And, we spend a lot of time perseverating on what the topic should be and who the speaker should be. And as you've seen, we've done this for many decades now. Next slide, please. And we do have a conference partner. So we are sort of partnered with several national behavioral health organizations, including the National Association of County Behavioral Health and Developmental Disability Directors, the Western Interstate Commission for Higher Education, and the National Association of Mental Health Program Directors. And all these organizations are represented on our executive committee. Next slide, please. And once again, I'd like to thank the sponsors for this year's conference, and the three of them, and the three organizations are Access Health Louisiana, Benchmark Human Services, and Genoa Healthcare. Next slide, please. And I'm just going to go over some quick housekeeping instructions. Please use the Q&A function to ask questions or make comments. It's very helpful if you can include your name and state. And generally, we'll have the Q&A responses by all the speakers after everybody's had a chance to make a presentation. CEUs are available. Closed captioning is available. And if you need that, you need to turn on the subtitle function at the bottom of your screen. And then at the end, we have an evaluation. Actually, we have two evaluations, one for people who are doing CEUs and one for the session at large. And there will be a screen that comes on when you click off this Zoom conference. And if you click on that, it'll take you directly to the SurveyMonkey evaluation form for this session. Next slide, please. And, I think all of you have, many of you have got this information in prior sort of letters and emails that you've got. But if you haven't, the way to register for CEUs is to send an email to Melanie Norwood at melnor64@yahoo.com with the subject NDBH CEU request. And then and she'll send you a CEU evaluation form. And you have to include a code word on the CEU evaluation form that you will receive from me or somebody else presenting at the end of this session. So, but we won't give it to you till everybody has presented. Next slide, please. If you want, this is the URL for the session evaluation. And, you can obviously note this down and go to it if you're leaving early. But right now, this will also appear on your screen at the end of the Zoom session, and you can click on it and it'll take you straight there. Thank you again for being here. I really appreciate everybody's attendance. In the prior sessions, we've had a lot of very good discussion, and at least from the initial evaluations we received, everybody seems very happy with the topics and the speakers and the discussion we've had. With that, I'm going to turn it over to Mary, and thank you all once again for attending. Thanks.
Thanks, VJ, and good afternoon, everyone. Thanks again for joining us today. So today's session will focus on strategies undertaken to address and reduce disparities in access to behavioral health treatment, as well as treatment quality and outcomes experienced by people of color who have been traditionally referred to as minorities. Health disparities and behavioral health disparities are, as we know, for these populations, long-standing public health issues. As such, initiatives have been undertaken over the years at the federal, the state, and the local level to address health and behavioral health disparities, some with greater impact and greater success than others. Despite this fact, great disparity continues, given existing systemic and social determinant factors. And it appears that these disparities have been exacerbated as a result of the COVID-19 pandemic, with data showing that racial and ethnic groups traditionally experiencing behavioral health-related disparities have experienced even greater negative impacts than individuals identifying as white, non-Hispanic over the past year and a half. For example, as recently as just 2 days ago, October 19th, the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association issued a joint statement declaring a national emergency in children's mental health, specifically noting, quote unquote, inequities resulting from structural racism have contributed to disproportionate impact for children from communities of color. Given that there has been recognition and a focus on behavioral health disparities, what lessons can we take from initiatives that have had some impact prior to the COVID-19 pandemic, in conjunction with lessons that we are learning during the pandemic, as well as lessons learned through science and research to continue to adapt and design behavioral health systems and services to better address these disparities? This is the important question that our panel will address this afternoon. So I'm going to go ahead and introduce all three of the panelists, and then we'll come back and we'll have our first presentation. The first presentation will be by Dr. Jeffrey Vanderploeg. He will describe strategies being undertaken to address behavioral health disparities experienced by children and adolescents in Connecticut, applying lessons learned prior to and during the COVID-19 pandemic. Dr. Vanderploeg is the president and CEO of the Child Health and Development Institute, which is an independent nonprofit organization located in Farmington, Connecticut. CHDI's work, conducted in partnership with state agencies, providers, advocates, and other stakeholders, has helped to establish Connecticut as a national leader in comprehensive, equitable, accessible, high quality, and outcome-oriented behavioral health services for children and their families. Dr. Vanderploeg was the lead author of the state's 2014 Children's Behavioral Health Plan, which is the state's blueprint for guiding investments and enhancements to the children's behavioral health system. The second presentation today will be made by Dr. Heather Gotham, which will focus on the use of implementation science and research to support implementation of evidence-based treatments by providing support and technical assistance to a network of centers funded by the Substance Abuse and Mental Health Association, SAMHSA, many of whom are addressing behavioral health disparity issues as part of their missions. Dr. Gotham is a licensed clinical psychologist and clinical associate professor at Stanford University School of Medicine. She's the director of the Mental Health Technology Transfer Center Network Coordinating Office, which is a SAMHSA-funded national network of training and technical assistance centers. Dr. Gotham's research focuses on implementation science, including factors affecting implementation and training and education of healthcare providers across a range of evidence-based practices for both adults and for adolescents, substance use and mental health disorders. They also address co-occurring mental health and substance use disorders and screening, brief intervention, and referral to treatment known as SBIRT. The third presentation today will be by Mr. Victor Armstrong, who will discuss strategies used by the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services to address behavioral health disparities for children and adolescents, using lessons from initiatives undertaken prior to the pandemic and lessons garnered throughout the course of the pandemic. Mr. Armstrong is currently the Chief Health Equity Officer for the Department of Health and Human Services for North Carolina. Prior to that, he was the director of the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, which had oversight and responsibility for the public community-based mental health, intellectual, and developmental disability services, as well as substance use and traumatic brain injury in North Carolina. So without further ado, I know that I'm excited to hear these presentations. So I am going to turn it over to Dr. Jeff Vanderploeg.
Hi, everyone. Thank you, Mary. Thank you, VJ. It's a pleasure to be here. My name is Jeff Vanderploeg. As Mary mentioned, I'm the CEO at the Child Health and Development Institute. And I have 25 minutes to talk with you about a lot of work that's happening in the state of Connecticut in this topic area. I'll pull up my slides in a moment, but I wanted to start with a very quick story and dig right into my 25 minutes, which I suspect is going to go by quickly. But I've been in touch with Stephen Philippi, who's on the executive committee of the National Dialogues Conference, and have been doing some work with him around mobile response for children. And so when he asked me to be part of this conference, I said, sure, thinking probably would be something around the mobile response system. And when I got the invitation from VJ and Mary around equity and racial justice, I was sharing that invitation with my wife, and she looked at me and said, really, you? Are you sure they sent the right email to the right person? And I said, yeah, right. Maybe, I'm not sure. So I almost said no to this, but then I got to thinking and talking with her, and we decided, oh, she said to me, you really should do this, because there's a lot of people just like you out there who are in positions, working in organizations or helping systems develop children's behavioral health, who need to be involved in this work. And you need to speak to that, including all the warts and the difficulties and the mistakes that come along with it. So I share that with you just to say that I don't consider myself an expert in the space. I do think that we've done some good work here at CHDI in the state of Connecticut. And my hope and expectation is that the mistakes, and maybe some small victories, will help you get involved in the game. Because I know for a lot of people, that initial fear to get involved in this work can be a real barrier. So that's just my message of encouragement to you all, as well as just a little bit of the humility I hope that I'm bringing into this conversation, not considering myself an expert. So with that, let me go ahead and get started with my slides, and hopefully everyone can see me. Let me know, Mary or Jessica, if there's any difficulty seeing the slides here. But today's presentation, as Mary said, is on enhancing equity and access, quality, and outcomes for children's behavioral health. And I'll be sharing a lot of examples from the state of Connecticut. I want to talk with you a little bit about what our children's behavioral health system looked like before the COVID pandemic, and also now and beyond. Also talk with you about some of the activities we're engaged in and to address racial equity, some of the elements of our children's behavioral health plan that have helped guide our work in this area, and also talk with you specifically around findings from studies and other data and QI projects we have going on here in our state that are helping to identify and address racial ethnic treatment outcome disparities. This is a very dense slide, and I promise you I'm not going to read all this or kind of cover everything, but I think when you look at children's behavioral health in the state of Connecticut, I think it's fair to say that we've had for a long time a fairly robust system. It started in the mid-1990s with a dramatic shift from a majority of spending and attention on residential and inpatient services to a system that was more aligned with a system of care values and principles, and a heavier emphasis on home, school, community-based systems of care. We have a Medicaid behavioral health partnership that includes our child and adult mental health and substance abuse services. That's the assistance coming from Beacon Health Options as the administrative services organizations for our Medicaid system. We're also fortunate to have the vast majority of young people in the state of Connecticut with some form of health insurance. And those numbers, 96%, might have even been before Medicaid expansion. So most children in our state have insurance. We have a very strong and robust community-based provider network that includes a number of child guidance clinics and grassroots organizations and school-based health centers. We also have two very strong family advocacy organizations that have a voice in our system development and implementation, a number of system of care grants from SAMHSA that have helped us with planning, implementation, and sustainability of system of care values, a statewide behavioral health data collection and reporting system for the majority of our funded behavioral health services in the state, a very robust continuum of services. You can see some examples there, a number of clinic and school-based and in-home evidence-based services, statewide mobile crisis that's available for all children free of charge in our state. And then, as Mary mentioned, and I've referenced already, a statewide children's behavioral health plan that helps guide our investments. So again, I think fair to say we've got a robust system here, a lot of things to feel good about, but then the pandemic hits. And I think probably similar to a lot of your experiences, became acutely aware of the limitations and the gaps that we still need to address. Our system, as many systems are in our country, way too fragmented when it comes to children's behavioral health, and difficult or even nearly impossible for family members to navigate when a crisis situation occurs or a mental health need comes up. And we hear it all the time. Where do I go for answers? Who do I need to talk to access services? I don't understand how this works. If am I enrolled in Medicaid, what can I get? I have a commercial insurance plan. What do I have access to? There isn't really a single point of access or a no wrong door approach into our system. There's a lot of information available through 211, and I think we're excited about the implementation of 988 in our state of Connecticut, as I'm sure many of you are as well. That might start to resolve some of those point of access issues. We also became very aware of a shortage of inpatient and residential treatment beds. I mentioned earlier that drastic shift that we made from inpatient and PRTF in the mid-90s towards a more community-based system over the last 20 years. But I think we're experiencing now that we're short. We're short on that deeper end of inpatient and PRTF. We also have a really important need to build competencies and availability for young people with intellectual developmental disabilities and autism spectrum disorders. I think we also became very aware that telemedicine access was a gap in our system, and we've been seeing some of the benefits of having a stronger presence of telemedicine now in the pandemic period and it looks like we're very hopeful that that is going to be a permanent extension of accessibility for young people and families. And right now, as we speak, are in the midst of a behavioral health emergency department surge that has really caught the attention of many people. And although it's overall bad news, the good news is that it has seemed to shake loose a lot of things that were stuck in our system and really addressing some limitations around urgent care, around crisis stabilization units, and things that we need to help alleviate the ED crisis. And of course, all of this happened at the same time George Floyd's murder and a racial justice reckoning in our state, and we became even more acutely aware of how equitable or inequitable our system was at many points and how much work we have left to do in our state in that area. So that hopefully provides some backdrop for you of both the strengths and limitations of our system. I want to share with you, I'm going to probably skip this slide because I think this is likely to be well addressed by some of our other panelists, but there are a number of factors that contribute to the disparities we see by race, ethnicity, gender, sexual orientation, and many, many other factors of diversity, ranging from stigma and social inequality and racism and discrimination to unaffordable or insufficient insurance coverage, issues around social determinants, clinic versus homeschool and primary care service delivery, choices that we make as system partners and how we design our service delivery system, and also limited funding and rates that are available to support a robust provider network and to maintain workforce, which I know is something that this National Dialogues Conference has paid attention to in past iterations of the conference. Also limited diversity in terms of our providers' language and culture, and how well our provider network and our workforce matches the characteristics of the populations being served. So I'll pause there and just say that there are solutions and steps that need to take place everywhere: system, policy, practice, and organizations. But I guess I would also add to that individual leadership, where we need to make investments in ensuring that we can address equitably access, quality, and outcomes in behavioral health care. So let me speak briefly to you about the Children's Behavioral Health Plan. This was in 2014, something that came out of unfortunate and tragic Sandy Hook shootings that took place in our state, not too far from where I'm sitting right now. And as a result of that, our legislature stood up and said, we have to do something about the behavioral health crisis facing our young people, and charged our Department of Children and Families, who oversees children's mental health, with coming up with a framework or a plan that could guide investments and enhancements in our behavioral health system. And there were a number of elements in there that had to do with racial justice or inequities and disparities. Although I will tell you, I look back on it now 7 years later and realize how insufficient some of the specificity in those areas really was. It doesn't mean that we haven't been able to make some important changes and progress in this area. But when I look back at it now, I say, boy, if I have a chance to rewrite this thing at some point, I think there's a whole lot more that we can say and do to talk about the goals and objectives that we may set for children's behavioral health in this area. So you can see here a number of goals around developing standards of culture and linguistically appropriate care, enhancing availability and access and delivery of services that are culturally and linguistically responsive in the areas of training and supervision, but also in recruitment and retention of a diverse workforce. And again, lots of good ideas, and we've made some progress, but so much has happened over the last 7 years. We would love to be, we want to do more. There's plenty of opportunity to do more. And this isn't just happening in the behavioral health system, as you're all well aware. In other systems that are critical to children's well-being and development, we see similar calls for racial justice. So in our education system, the use of ESSER and ESSER 2 funds in education have included an emphasis not just on enhancing social, emotional, behavioral health for young people, but doing so in such a way that it addresses inequities. And we're proud in the state of Connecticut now that Secretary Cardona is actually the former Commissioner of Education here in Connecticut, and the new SAMHSA Director, Secretary Miriam Dalphin-Rittman, also came from Connecticut. So on one hand, we're super proud of that. On the other hand, we're also saying, federal government, please stop taking all of our wonderful people and moving them to DC. But that being said, they're great advocates, wonderful people in the education and behavioral health world, and I think are going to do tremendous work at the federal level to help move some of these things forward. There's also, as many of you know, the Family First Prevention Services Act that was passed a couple of years ago that really makes a dramatic shift in federal policy and makes available for the first time prevention services. So instead of just being able to tap into federal reimbursement for kids already in foster care and adoption, Family First essentially makes available services, particularly evidence-based services, to prevent young people from entering foster care. So that's a very dramatic change. I'm certain that many of you on the call are deeply involved in this. But this makes available and expands the accessibility of evidence-based mental health and substance abuse treatment programs, as well as in-home parenting skill-based programs. And in our state, that has fit well with our Child Welfare Authority in terms of their view, and you can see at the bottom there, their view of safety, permanency, well-being, which is maybe a familiar framework for those of you who have worked in child welfare, but it also incorporates a racial justice lens that applies throughout our continuum of child welfare services and also has implications for our workforce. And of course, in juvenile justice, this has been an issue for years and years. We have a juvenile justice policy and oversight committee that includes a racial and ethnic disparity work group that's been working on this issue in juvenile justice for a number of years, and recommending some really important legislation and policies to help make significant advancements in the disproportionality in our juvenile justice system by race and ethnicity. And many of these young people involved in juvenile justice, by the way, up to 70% by some research out there, have diagnosable behavioral health conditions. And wouldn't we be better off as a society if we were addressing those needs early in the behavioral health system, as opposed to getting them involved in the juvenile justice system, often unnecessarily? And I'll speak to a program later on today where we've tried to make a dent in that issue. So that those slides talked with you, it just shared with you some of the developments at the systems level in Connecticut, some federal policy changes focusing on equity. And so now the question is, what can we do to support our organizations delivering behavioral health services to address equity and reduce disparities? One thing that we've invested here in Connecticut is an investment in our culturally and linguistically appropriate services standards. And if you're not familiar with CLASS, it's definitely worth clicking on the link at the bottom there. The purpose of the CLASS standards are to provide a blueprint for individuals and healthcare organizations to implement culturally and linguistically appropriate services that advance equity, improve quality, and help eliminate healthcare disparities. So that's pretty much center of the bullseye. That's what we're all going for. And I think the CLASS standards are effective for helping engage provider organizations in a phased process to develop health equity goals, and almost like a breakthrough series or IHI approach, where they develop goals and engage their entire organization in advancing their equity work. So you can see here how the 4 phases of that roll out, and really it's focused on making those changes at the organizational level to help these organizations develop goals and health equity plans that move the needle on racial justice and reducing disparities. So we've been able to engage on this data may actually be a little bit outdated. I think the numbers are a little higher now, but 56 organizations up to this point have been trained in a 6-month cohort process or an accelerated cohort. 35 of those agencies have developed health equity plans, and 6 more are in the pipeline. Over 200 individuals have been trained. Yes, we're using more of a train the trainer approach here in order to advance the spread of this work. We've developed a toolkit to help organizations move this forward so that it doesn't rely on extensive tech training and technical assistance availability at all times, but organizations have a toolkit where they can help move the work forward themselves. So that's been very exciting. And like I said, we've seen more organizations engaged and involved in this work over time. I would like, so as we're talking about organizations, we have a role in working the CLASS and health equity plan process with behavioral health organizations delivering direct care in the community. But we have a journey to go on ourselves here at CHDI as we engage in that consultation and TA process with other organizations, because how can we ask them to do this work if we're not doing it ourselves? And again, this is not to say that we're experts in this work, and we have certainly made our mistakes along the way, but we've also had those small victories, particularly over the last couple of years, that we feel good about here at CHDI. And I share it with you just to give you a few ideas from where you're sitting about how you can advance your own organization's work in this space. Because if you're not professionally developing yourself as a leader and not developing your staff who's doing this work in the community, I think that has to come first. And we have to take responsibility for that individually and as leaders in each of our respective spheres to really invest and engage in that area. So we have a care committee here and at our organization that really guides our work. There's a lot of young people that serve on that committee, which I think has been really important. It's not some of the more seasoned folks like myself that are leading these conversations. We are really relying on our young people to point the way for us, because they're steeped in this work in a way that many of us who have been around for longer have not been. We also have received consultation from Health Equity Solutions, which is a consulting shop here in Connecticut led by Takesha Everett. We have an anti-racism strategic plan that we're developing right now and putting some finishing touches on. I did for the first time, offer a stipend for a staff person to lead our care committee and to work with our consultant and really lead the way for our work here organizationally. And we have a senior management sponsor who helps support that staff person. We have all staff workshops throughout the year. We have an affinity group that meets around identity and intersectionality. We have culture sharing events throughout the year. We have asked all of our staff to include equity and anti-racism goals in their annual review process. Every staff member, if you're involved in our finance department or you're preparing grants and contracts as your 40 hours a week, you have to have a health equity goal as part of your annual review. And we're also making updates to our employee handbook and changes to our annual staff survey so that we know if we're making progress in these areas. So again, I share those just as some ideas and examples and things that you can take on at your organization. I hope I'm doing okay on time, so I'm going to keep moving until somebody sends me or comes off of the mute and says, Jeff, you've got 30 seconds left. So as I keep moving here, some key questions you have to ask yourself in building children's mental health systems. I'm going to focus mostly on that second bullet. There is a difference between making services available and making services accessible. And that's a lesson that we're still in, a journey that we're still on in Connecticut. We find that the services that are mobile, that are in homes, that are in schools, and that are co-located in primary care settings tend to be more accessible than those that are available in center-based locations. That's not to say that states need to move away from center or office-based mental health services, but we find that services are more accessible when you bring them to populations most in need. And we have asked ourselves the question over the years, do our evidence-based services that we have invested so much in Connecticut, are they actually working for children and families of color? Do we even have the data that we need to answer these questions? The Field of Dreams connection, if you recognize the picture, it's that notion of if you build it, will they come? Well, if you build services and you kind of put them in an office, they may not come. So that's something that we've grappled with in our state. We have a mobile crisis program that's very strong, I mentioned earlier. That is a service that can be deployed. We have a single statewide call center to access the service. We are able to deploy each of those little red cars on the map of Connecticut. There are locations for our mobile crisis teams that allows them to get out to a family's home or a school or even an emergency department. Our median response time is 29 minutes. And we are a 94% mobile service, meaning, for every 100 calls that comes in requesting a mobile, 94 of those calls actually get a face-to-face mobile visit. So we are not telephone triaging our children's mobile crisis service system. We are sending providers out there into the communities, into homes, into schools, and addressing crisis situations so that we can reduce both emergency department visits as well as unnecessary entanglement in juvenile justice. So just an example of how you can build things that go out to the community. There is so much data we could share around mobile crisis, but on the top, you can see what our utilization looks like in our mobile crisis population versus our Connecticut total population. So for example, 11% of youth in Connecticut are African-American, but 18% of users of our mobile crisis service system. And towards the right, 23% are Hispanic or Latinx in our state, but 32% of our users in mobile crisis are Hispanic or Latinx. And then if you have information on race and ethnicity, and you have information on age and gender, you can look at all those cross-section statistics and find out for any given service, what does our utilization look like by race, ethnicity, by age? And it helps you answer some really interesting and important questions. So we have found in our mobile crisis service system, for example, that Black and Hispanic children have significantly higher likelihood of being referred by schools and referred for disruptive behavior when you compare them to white children. So having this kind of data allows you to dig deeper into your system, answer important questions, and be able to leverage your training, technical assistance, and quality improvement activities with providers to address those issues. Many of you are familiar with the term of the school to prison pipeline. And we have an initiative here in Connecticut called the School-Based Diversion Initiative. I was involved in as one of the co-developers of that model 12 years ago to address this issue of young people who are arrested for school incidents, and it happens all over the country. We've been able to do that work now in over 60 schools over the last 12 years, and have found on average in that first year or sometimes 2 years of implementation, a 36% reduction in juvenile court referrals and a 28% increase in referrals to our mobile crisis service system. So those are youth that otherwise would have ended up in an emergency department or arrested. So you can see there graphically what that looks like. In orange, the number of calls from a previous school-based diversion year to the current year. Calls increased to mobile crisis, and referrals to JJ decreased significantly over time. And once again, if you dig deeper into that data, what you find is that you can look at trends related to age, related to race and ethnicity. And so just as one example, this is a dashboard we put together for one school on our school-based diversion initiative, where we could show a reduction in court referrals or a reduction in disparate court referrals during SBDI participation for Black and Hispanic youth, as well as an improvement in their rates of referral to our mobile service system as an alternative. We also published a study recently looking at youth that received evidence-based treatments in our outpatient services system. We use administrative data on over 46,000 young people served in 25 different outpatient clinics across the state over a 4-year period. And what we found is it at least partially started to answer the question I posed earlier, which is, do our evidence-based treatments actually work for young people of color? And what we have found in this study is that that last bullet, evidence-based treatments do in fact, in this sample, in this study at least, reduce the disparities that you see in outcomes for Black and Hispanic children. So when you compare this to evidence-based treatments to what we would call treatment as usual or non-evidence-based, there is a reduction in the disparity for the evidence-based treatments to a greater degree than the wider disparities that you see in usual care. And this kind of data makes an impact. So the bottom is a screenshot from the Hartford Courant, where, and I will tell you just as background that there was an official in the department who was very, very skeptical. Like, what all this investment in evidence-based behavioral health services? We know they don't work for children of color. We were able to put this in front of the officials at that department, and it made a dramatic change. It made a dramatic difference in policy and in decision-making about where we invest our finances. So where are we heading based on all this? I look back at that early slide I shared with you around our gaps. And I think there's lots of work for us to do. We have to do our system building within the context of racial justice and health equity. That's number one on the list. We have to do a better job of system integration. We have to do a better job of pooling and blending our funding and sharing governance and responsibility across child serving sectors. I think 988 is going to be an important step towards better accessibility for all families in the state. And we need to do a better job of creating that no wrongdoer approach through things like care management entities. We are in the process of looking at increasing our inpatient and PRTF bed capacity, expanding mobile crisis, which, as you saw earlier, is more accessible to families and communities of color than other parts of our service system. We need to create alternatives to our emergency departments. Part of the reason that kids go to the emergency department for services, because they can't go other places. They aren't available. So we need to build behavioral health urgent care here in our state, as well as longer term crisis stabilization services. We are advocating and working towards permanent telemedicine reimbursement policies here in our state. And I mentioned earlier our workforce issues. That is going to be, I suspect, a long-term commitment to invest in our workforce, in part by increasing funding and increasing rates across the board, across all levels of care, so that we can recruit and retain a diverse and workforce that matches the significance and importance of the work and issues that they're addressing. And we need to continue building capacity to identify disparities at the system and provider level. We got to do that by aligning our efforts, again, investing in our workforce, translating our data into action. You got to have the data first, right? And I know that's a challenge for many places. We don't have that kind of data. Well, you have to build it. We have to build the data. We need to know the characteristics of our population served in order to know where our disparate outcomes and access points are. And then we have to have the courage to act on that data. And so we want to continue focusing on leading and going down this path of more services that are mobile, that are home-based, that are school-based, that are primary care-based. And again, I shared with you the study where we saw some high promise for evidence-based treatments for families of color. So with that, I will stop right there and turn it back over to Mary.
Jeff, thank you. That was an excellent presentation. And you came in just on time. so I'm overly impressed. I know that we said we were going to save all of the questions until the end, but I am going to pose one question, before we go to the next speaker, that someone posed. And that question is, can you give some examples of some of the health equity goals that appear in folks' annual job or performance review?
I wish I could pull one up right now if I knew that question ahead of time. That is a very good question. Let me think of an example here. For some people, it might be just getting more deeply involved in our care committee internally. That right now we have a third to a half of our staff that are involved in our committee on anti-racism and equity. And so for some, the goal has been, I need to get involved in that work so I can learn more, be more aware of what the issues are, and know how to act upon them in my day-to-day work. For the data analysts that are part of our organization, there's also a subcommittee of care that we call DEEPER, and I'm going to totally forget what DEEPER stands for. But suffice to say that it focuses on how do we dive deeper into our data to get the kinds of results I was showing on screen earlier. And so for some of our data analysts, the health equity goal for the year might be getting engaged in the DEEPER committee so that I can advance my skills as a data analyst and be able to contribute to our organization's goals in this area, but also the broader state goals that we have.
Great. I think those are some excellent examples. Well, thank you. We will come back with more questions after everyone on the panel presents. So we're going to move on to our second presenter, Dr. Heather Gotham. Heather, take it away.
Thanks, Mary. And thanks, Jeff, for such a great starting us off. Let me share my screen. Again, I appreciate the introduction. And before I start, I wanted to acknowledge that as a white cisgender person, I don't have the full lived experience of the types of behavioral health disparities that I'll be discussing. My role is to present some strategies that can be used to decrease and eliminate disparities, all of which require working together with humility and genuineness. And I really appreciated Jeff's comments about how we need to come together to fight all of these disparities, to make progress and inroads on them, and really look to all of us as behavioral health professionals to create change. So my role is to talk a little bit about the training and technical assistance aspect of behavioral health disparities. So Jeff did a great job. I think coming from the provider perspective, I'm so impressed with Connecticut's strides in all of these areas, and specifically for children's mental health services, which is why the federal government keeps taking your great folks. So I represent the Mental Health Technology Transfer Center Network, which I'll describe a bit later, which is a network of training and technical assistance centers funded by SAMHSA. And I'm going to talk about that network as well as a number of other SAMHSA funded training and TA centers. So just to think about it from a little bit of a different perspective, just a disclaimer that these are my thoughts and not those of the federal government. So trying to keep in mind the focus on this conference on the future of behavioral health after, but shaped by COVID, I want to talk about a few of these objectives here. One is to define some behavioral health disparities. I think Jeff and Victor and I all have a section of that in our presentations. Talk about those both pre and during COVID. And then to talk about how single focus efforts such as cultural competency training are important, but not enough to produce behavioral health equity. And then really pull in implementation science, or D&I science, dissemination and implementation science, and talk about how those frameworks and research base, especially applied to training and TA efforts, can help decrease disparities, and then wrap up with introducing you to several SAMHSA-funded training and TA centers. I hope all of these things will help you feel more comfortable reading and engaging with D&I research, but also in if you're behavioral health providers and you're seeking out training and TA services, that you keep these in mind and how you can use them to change your practice. So again, similar to what Jeff presented, we in the US have really egregious and unfair disparities in mental health and substance use disorders. For example, there are disparities in diagnosis where racial and ethnic minorities are either over or underdiagnosed with mental health issues, including serious mental illness. Specific populations also bear a higher burden of disability. For example, rates of depression in people who identify as Black or Hispanic are lower than those who identify as white, but depression is more likely to be persistent in people who identify as Black or Hispanic. So again, higher burden of disability. And in addition, minority groups typically have less access to services, use services less, and are provided effective treatments less. So this chart shows the percent of people with any mental illness receiving services. This is SAMHSA data, which really shows, again, stark disparities in those who receive services. These disparities have their roots in systemic racism throughout the development of the health and mental health care systems in the US, and is part of what we all need to work to combat. This list touches on some of those barriers to effective care in diverse groups and specific populations, excuse me, all of which need to be addressed, again, to eliminate behavioral health disparities. So prior to COVID, we had these disparities, and then COVID certainly shone a spotlight on them. This chart shows the rates of cases of COVID, hospitalization, and death, and really shows the disproportionate numbers of folks who are not white or Hispanic, and again, the burden. COVID has affected these specific populations in ways that defy words, really. And again, part of that has to do with populations being less likely to receive adequate health care. And specifically with COVID, these populations are more likely to report COVID-related stress and increases in depression, suicidal ideation, especially among Hispanic and Latino respondents. So thinking about how can we address these behavioral health disparities? How can we, again, make inroads to move towards behavioral health equity? I wanted to highlight several myths about eliminating behavioral health disparities that I think have really held us all back from significant movement in this area. And the key one that I think has probably been most damaging over time, perhaps, is the idea that we just need to build a behavioral health providers that are more culturally competent. So everyone gets cultural competency training, which is part of the solution. It definitely is part of the solution, but is not the solution. And I think for too long, we treated it as such. So definitely need to branch out and think about other strategies. Another myth about eliminating behavioral health disparities is that all we needed to do was culturally adapt interventions. Again, that's an important piece of the puzzle here, piece of the movement toward equity, but not all that we need to do. Another myth was just to focus on testing the efficacy and effectiveness of the interventions in minority communities. Again, something that's needed and should be done, but is just a piece. And then that one size fits all. If we just scale up interventions, it'll improve the quality of care for everyone. And we know that has not worked. And then I think during the pandemic, we have seen even more clearly how several of these myths operate or don't operate and really fall apart. So for example, that idea of we just need to build a behavioral health workforce that's culturally competent, we saw during the pandemic, have seen and are continuing to see many community behavioral health providers that close programs or reduce their services, leaving everyone out, and especially outreach services, which were really beneficial to specific populations. And again, that idea of one size fits all, we just need to scale up all the interventions. So telehealth is one of those interventions that we scaled up significantly throughout the pandemic, but we see that telehealth platforms are difficult for diverse communities to access. So that is not all that needs to be done. Similarly, scaling up an intervention to improve the quality of care for everyone, we can look at the vaccine as a way to do that as well, right, with COVID. But we've seen a lot of vaccine hesitancy for some very, strong, important reasons in specific communities that again has resulted in not equity and continuing to have disparities in health and behavioral health. So we have these myths. How do we approach them? How do we move past them? How do we get around them? And so I want to talk a little bit about implementation science and implementation science frameworks and some research findings, again, that can help decrease disparities during COVID and also post-COVID. So if you're not familiar with the D&I science, a little primer here. So let's first talk about some common terms. Earlier in the history of this new science, there was a good deal of controversy about these terms and frameworks and theories. At this point, we have some consensus about a number of the terms. So I just wanted to have us all start from the same place here. So dissemination is a range of active approaches to spread an evidence-based intervention to target audiences via very specific channels and planned strategies. Okay, so dissemination means spreading the intervention out, increasing awareness of the intervention or the evidence-based practice. So that can include publishing articles, developing and mailing clinical guidelines or training manuals, and then the spread of basic information and awareness raising, such as through webinars. So dissemination, excuse me, I'm just getting over an illness and not quite there yet. So dissemination versus implementation. Implementation is really the process of putting to use or integrating evidence-based interventions within a setting. And there are a whole set of strategies, a set of implementation strategies or training and TA strategies that we can use to really push or accelerate implementation of research into practice. So implementation. And then sustainment, probably the term that's most accessible, is the process of maintaining or continuing the intervention beyond a more active implementation. So we know that even after a new innovation has been used in clinical practice for some time, it still needs care and feeding, meaning resources and other strategies and other activities in order to keep clinicians or a program using it. So background on terminology here. And then D&I science or D&I research is the scientific study of the processes and factors associated with the successful integration of evidence-based intervention. It has to do with how you get evidence-based practices into routine settings so that more people can receive the best care. And then over time, how do you keep the practice in place? D&I science has really been around for the past 30 years, more or less. It had its roots in some great work on hybrid seed corn in Iowa in the 30s and 40s, and pulled in then research from other fields, including marketing and communication and manufacturing. So at this point, D&I is robust, although still a young science, but it's a field that has its own theories and methodologies and journals and training programs. So with that kind of primer, I wanted to turn to think about how can implementation science help reduce behavioral health disparities? Again, this is just one kind of slice at how to make some inroads on these disparities. And I'm going to talk about 4 specific ways that I think D&I science can help reduce disparities and highlight that some of these are based on the work of Anna Bauman and colleagues at Washington University in St. Louis. So there have been a number of implementation science researchers who have really been thinking about disparities in behavioral health or in healthcare. And so I'm going to present some of their work over the next few slides to talk about these 4 specific ways. So bear with me on the model here, but this first way is the idea, if you all think about at times when you have implemented an evidence-based practice in a clinical setting or in a healthcare setting or wherever you've done this, right? You've made some kind of change. You can think about your own experience and you probably have some failed implementations in mind where you've tried to do something new and it hasn't worked. And really when people try to make changes, they don't often stick. And so there are a number of key frameworks in implementation science that try to capture those barriers and facilitators. Like what are the factors that affect whether or not an evidence-based practice sticks and is able to be implemented? We call that the context of implementation. So the setting, what's going on in the clinical space. And so I said there's a number of frameworks related to barriers and facilitators in implementation science. This specific framework called the Health Equity Implementation Framework takes, kind of combines research across implementation science and then really shows how it can be used to look at health equity. This was developed by Woodward and colleagues and explains factors relevant to the implementation of disparities in healthcare, but as applied to behavioral health as well. So you start at the center there with the clinical encounter, right? The clinical encounter between patients, consumers, and providers. And you can think about being a clinical encounter or an encounter in any kind of health or behavioral health setting with a peer specialist or whoever it is. And so that context includes things like patient factors, characteristics of the innovation, so characteristics of the evidence-based practice itself, characteristics of the providers or other recipients. And what's really important in talking about health equity is to get beyond that, right? So to look at that context beyond just what's going on in that interaction, because that's not all that's important. And so this model really looks at that context a couple different ways. One is through that kind of next ring out, where we're looking at factors in the healthcare system, which could be in the healthcare system within a state, the healthcare system within a hospital, the healthcare system within an organization, a behavioral health service organization, and then the context within that particular clinic. And then beyond that, what are those societal influences? And here, these are especially important to consider because of the impact they can have on healthcare and behavioral healthcare disparities. So the way that this can get used, I think that can be really important is even if you're thinking about implementing an evidence-based practice in your particular clinic or setting, as you think about planning, how am I going to implement this new, say it's motivational interviewing or it's dialectical behavior therapy or one of the programs that Jeff mentioned earlier, as you're thinking about how to implement that within your setting, you need to think about all these contextual factors and how can we measure them, how can we take account of them, and how can we look at them through a behavioral health equity lens in order to understand what do we need to do to make sure that the services that we eventually provide are equitable and are being provided across all populations. All right, so context is one. A second way that D&I science can be used has to do with adaptation. So every time an evidence-based practice is implemented, it's modified and adapted. Again, think about your own experience of implementing something new. You always have to change it, right, in some way to make it your own or to make it fit within your setting. And without documenting and evaluating the effects, we can't be sure if that adaptive practice is still effective. This becomes even more important when considering the practice's effect on diverse groups. So the general wisdom used to be that programs should just document what they changed and go along their way, and that's fine. However, my colleague, Shannon Wiltsey-Sturman and her colleagues developed a system for classifying the types of modifications that are made when interventions and programs are implemented and how they can facilitate efforts to understand the nature of modifications that are made in these particular contexts and the impact of these modifications on outcomes of interest. So this model for tracking adaptation is something that gets used in research, but is also, again, something that can be used by a training and technical assistance provider who's providing TA to a behavioral health treatment system, or can be used by the behavioral health treatment system itself as they're going about implementing an evidence-based practice. And one thing that I think is really key about this model, that is one of the things that makes it so important, is this, in that second box from the left, the distinguishing between what is modified, sorry, that's the name of the box, the distinguishing between the content and the context, right? So there's the content. Are you changing the content when you're adapting something, or are you changing the context? And that's a really key difference. Again, to think about using this type of tracking when modifying an evidence-based practice for a particular population, or even just when using it across the population and trying to understand how well this intervention is working. So adaptation, the second one. A third way D&I science can be used, which is really important for the training and TA work that I do, is about implementation strategies. So implementation strategies are really like the training and technical assistance intervention. So it could be a workshop or a learning collaborative, a webinar, some coaching. So there's some examples there on the screen about different implementation strategies or TA activities. What we know across D&I science is that passive dissemination strategies, such as research publications, training manuals, and even standalone trainings, right, aren't enough to change practice. You know this. You send folks to a training or a workshop and they come back. You can't expect them to just change the program overnight, right? A lot more needs to be, supports need to be provided around that evidence-based practice. So I think it's inherent in us to think about what kinds of implementation strategies both push practice change, but also can address disparities and build equity. So as it, again, as you're thinking about maybe you're a behavioral health provider and you're going to be focusing on or finding a TA provider to provide services, we want to think about what kinds of TA services are going to be provided. And so typically we have used these different approaches that are very imprecise. So we're going to do a training and just kind of hope that everyone changes, or we're going to do all these different things, provide you all this TA and it's going to work, without really trying to understand how the training and TA strategies relate to that context, which we talked about earlier, and also relate to behavioral health disparities and equities. So we really want to try and tailor the strategies to eliminate disparities and use strategies that take advantages of opportunities to promote equity, excuse me. And then real briefly, a fourth way that we can use D&I science, it relates to how we evaluate the implementation of an evidence-based practice. Excuse me. So this is a common model for evaluating implementation. It's called RE-AIM, and has 5 components. And for each of these components, as we're thinking about, again, both a training or TA provider who's implementing, who's providing services to a behavioral health group or a state, or if you are a behavioral health provider, to think about how am I evaluating the effects of this implementation. You want to address each of these constructs in RE-AIM, but also address each of these with a focus on behavioral health disparities and equity. And there are a few ways shown here to do that. So the last few minutes, I want to turn to talking about several SAMHSA funded training and TA centers that focus on behavioral health disparities. First, an introduction to our MHTTC network, which is where I'm from, what I'm part of. So this is a map showing the location of all of our centers. The MHTTC network is developed to provide training and TA services across behavioral across mental health prevention, treatment, and recovery supports. Were founded in 2018. And we have 10 regional centers that cover all the states and territories, which you can see here. We have 2 national focus area centers, the National American Indian and Alaska Native Center, the National Hispanic and Latino Center, which I'll talk more about in a minute. And then I'm from that network coordinating office. So as I said, we provide regional and population tailored services to states and treatment provider systems. We work really closely with SAMHSA regional administrators in each of those 10 regions, with state behavioral health commissioners and local stakeholders to understand what are the pressing needs in the region or population. And then we develop training and TA services to meet those needs. And we really try to use D&I science to inform our services. So that harkens back to some of the things we just talked about in terms of looking at the context. What are the local or regional barriers and facilitators to implementation? Try to use precision implementation strategies that are specific to the need. Again, not just throw training or webinar at people, but really understand, I think you might need some coalition building, or maybe it's coaching. Maybe a learning collaborative across centers would help. Really trying to maximize our impact on service delivery systems. The MHTTCs that have been and are committed to addressing social determinants of health and disparities in access to and receipt of effective healthcare services. And so we provide training and TA to improve access to culturally responsive mental health services, and to promote mental health equity. This is just a few examples of our either events or products we've developed over the past few years that get at this important topic. In addition, we have 2 national focus areas, as I mentioned, that are specific to specific populations. So the National American Indian and Alaska Native MHTTC is housed at the University of Iowa, and their mission really is to strengthen and promote systemic behavioral health practice changes that honor and contribute to the health and well-being of American Indian and Alaska Native communities, tribes, and individuals. So you can visit their website to find out more about their specific services, but here are a few of the things that they've been working on recently. They have a 3-day curriculum on how to provide services to Native clients. They look at that adaptation piece and looking at motivational interviewing specifically and doing some cultural adaptation training there. They have a really great Healing the Returning Warrior set of training and TA services for folks who are providing behavioral health services to returning Native veterans, as well as some skills-based sessions. They also have done, especially during COVID, a lot of listening sessions. They call strategies of support in order to hear from providers who are serving Native American and Alaska Native populations and better understand what their needs are during COVID. Very brief introduction to that center. And then our National Hispanic and Latino Center is housed at the University del Caribe in Puerto Rico, and they serve as subject matter experts and resource for mental health providers and school-based mental health workforce across the US and territories. Similar to the other National Focus Area Center, they provide a number of training and TA services and develop products related to their population. Here are some examples recently. They're really focused on trauma-informed services for Hispanic and Latino populations. That's one of their areas of expertise. They've done a lot of work, especially just this past year, related to immigration, and have a number of really great products related to Latino Indigenous populations. They also have a focus on gender violence and some work in suicide as well. So again, visit those websites for more resources. So I've been talking about the MHTTC network. Just want to present a couple more SAMHSA funded training and TA centers for you to check out. In addition to the MHTTC network, we have 2 sister networks, the ATTCs, which are the Addiction Technology Transfer Centers, and the PTTCs, which are the prevention, meaning substance use prevention technology transfer center networks. Our 3 networks are set up the same way. So each of them have a National American Indian and Alaska Native Center and a National Hispanic and Latino Center that are providing training in TA around addiction treatment and substance use prevention. Definitely want to check those out. In 2020, SAMHSA funded 3 additional centers of excellence on behavioral health disparities. So these are our new colleagues in this work. The African American Behavioral Health Center of Excellence is located at, I'm sorry, the name just escaped me. My apologies. A historically Black, I'll put it in the chat when I remember it, my apologies. In Atlanta, we have the Center of Excellence, LGBTQ plus Behavioral Health Equity at the University of Maryland, and the E4 Center of Excellence on Behavioral Health Disparities and Aging, which is located at Rush University. Want to check those out as well, all providing training in TA across the United States on behavioral health disparities in those particular areas. And then one last training in TA center to point out, excuse me, that SAMHSA funded is the NED, the National Network to Eliminate Disparities in Behavioral Health. So they're function a little bit differently than the training and TA centers I was just talking about. They're really a network of community-based organizations that focus on mental health and substance use issues. They do provide training and TA services, but also provide connections to these community-based centers that are serving populations and doing a really great job serving these populations, providing culturally relevant and tailored behavioral health services. So the NED is a great resource as well. SAMHSA's Office of Behavioral Health Equity has really made great strides to increase the focus throughout SAMHSA on behavioral health disparities. Real briefly, as I think I'm about at time here, in terms of thinking about the future, fast forwarding past the pandemic, a few things that I think are important. Again, as I've been talking about, really trying to broaden the focus from just cultural competency training to look at other ways that we can help address behavioral health disparities. And again, my slice I've been trying to, or view I've been trying to look through has to do with training and TA informed by implementation science. So what we've seen in terms of how our work has changed pre-COVID, during COVID, and thinking about the future is during COVID, we really had a focus on very brief webinar-based kinds of trainings. You know, all of our work moved from most of it being in person to being virtual. And we were really, I think, proud to provide that during COVID kind of on the ground important information that clinicians needed as things were rapidly changing. So we did a lot of work in telehealth and bringing telehealth to understanding of how to do telehealth to the behavioral health provider network. We also looked at some key clinical applications, like how do you do suicide care, or how do you try to monitor for domestic violence and intimate partner violence when things are all virtual. So we were glad to provide that, but we're hoping and hopeful that post-COVID, as things settle down, that we're able to go back to providing that more in-depth implementation support, which is really where the D&I science piece comes in. And as always, trying to increase attention on and to mental health equity, so that we're not just looking at implementation of evidence-based practices, but we really have that lens and focus all the time on mental health equity pieces. That is the end of my remarks, and my contact information is here, and please reach out, visit our website if you're interested in the work of the MHTTC network. Thanks. I'll send it back to Mary.
Thank you, Heather. Thank you for a thought-provoking presentation. I do have a couple of questions, but I think they're going to be broad, and so we'll probably want to hear from everyone on the panel. So I'm going to hold those couple of questions until the end. So having said that, let's go to our next panelist, Mr. Victor Armstrong.
Thank you. And I am extremely pleased to be here with you this afternoon. I do want to just say a couple of things just to kind of, I think, level set about some of what I'll share and really the perspective I'm coming from. When I was first asked to do this, which was not that long ago, I was actually sitting in the role of director of the North Carolina Division of Mental Health, Developmental, Disabilities, and Substance Abuse Services. So I was the mental health commissioner for the state of North Carolina. And just a couple of weeks ago, on October 1st, I moved into a new role as our state's first ever Chief Health Equity Officer for the Department of Health and Human Services. And so a lot of what I'll share, I think, while my perspective hasn't changed and what I'll share hasn't changed, I think my lens is probably going to be a little different, maybe than it would have been a few weeks ago, only because I think that our lens is influenced by where we sit, because our path forward depends in large part on the resources that we have available to us. And so I think that will probably frame a little bit of how I talk today, because part of what I think we have learned from the pandemic is that we need to partner differently and think differently about how we not only access communities that have been historically marginalized, but also how we hear from those communities and how we learn from those communities. I think part of the challenge that we have had, we think in terms of systems, particularly large systems like state systems, is that we tend to think very much in aggregate terms historically. And we have really had more of an approach of providing more access benefits everyone. And I think one of the things that we have learned clearly from the pandemic is that not all access is equal access. I think we also learned that while we definitely need more evidence-based and evidence-informed practices in our local communities, we also need community-informed practices. And we need to listen to our communities and our stakeholders on how we can better serve them and what is going to work for them in their communities. So that will also shade some of what I'll share today. The other thing I want to say is that as we're having these conversations about lessons learned during the pandemic and the path forward, I think we also need to understand that for historically marginalized communities, and particularly I think in the Black community, and I'll say Black and Brown communities, when we think about this last year and a half, going on 2 years now with dealing with the coronavirus pandemic, I think we also need to understand that for many people of color, and I include myself in that as I say this, that the pandemic has not just been about the exposure to a virus. It really has been a span of time. And I think when we look back on the pandemic, we won't just think about the pandemic in terms of just coronavirus. We'll also think about the civil unrest that we've seen play out over the last year and a half. We'll think about not only being isolated sitting at home, but we'll think about sitting at home and seeing what played out happening to George Floyd and Ahmaud Arbery and Breonna Taylor. And so when we think about how we move forward, particularly as we're talking about mental health and the mental health of children and adolescents, I think that we have to take those kinds of things into account. So as we are talking about and focusing on disparities, health disparities for children and adolescents as it pertains to race and ethnicity, we need to keep those things in mind. Do you have the slide deck up? I can't. Okay, there we go. All right, let's move on to the first slide, please. So I do want to share a little bit about the backdrop of services in North Carolina, just to give you a little bit of the flavor of what we experience here in North Carolina. Here in North Carolina, each year there's an estimated 390,000 children in our state, and that's 20% of our total child population, that have a diagnosable mental health condition. And in 2019, suicide was the second leading cause of death for people between the ages of 15 and 34, and third for those 10 to 14 in North Carolina. Next slide. Also, when we look at pre-existing conditions and gaps in insurance coverage for historically marginalized populations, which again impacts the way that we access care. In 2018, North Carolina's uninsured rate was 12.7%. And that's the 10th highest rate of all of the 50 states, meaning that over 1 million people were uninsured. The rates of being uninsured are higher for historically marginalized populations than they are for our white counterparts. And of North Carolinians under the age of 64 in 2018, 28.7% of those who are Hispanic were uninsured, and 12.6% of those who are Black were uninsured, compared to 10% of those who are white. Next slide. And we look at some of the baseline pre-pandemic unmet needs. And again, I emphasize this was pre-pandemic. We look at having about 10.6 million North Carolina residents. Of those 10.6 million, about 1.8 million receive Medicaid, about 7.6 million receive private, military, or Medicare insurance, and another 1.2 million are uninsured. Children are about 53% of our Medicaid population, but they only account for about 23% of the service spending. And I'll talk a little bit about some of the impact of that as we move forward, because many of the challenges that we have experienced both pre-pandemic and that have been really exacerbated by the pandemic have impacted our children disproportionately. In terms of access, North Carolina is 42nd in the country in youth access to needed behavioral health services. North Carolina has seen an almost 25% increase in the number of uninsured children from 2016 to 2019. And 90 of the 100 counties in North Carolina face a severe shortage of child psychiatrists, and 64% of our counties have no child psychiatrists. And part of the reason I share that too is because not only does it point out the shortage of psychiatrists and children's services in our state, but I think it also points to the fact that we need to do something different in terms of how we are accessing care for our young people, because we clearly don't have the access to psychiatric services and psychological services that we need to effectively treat our children in this state. And so I think that speaks again to us looking at how we partner differently, how we respond to young people. One of the things that I will share with you as we are thinking about our approach to mobile crisis services and crisis services, particularly for children, one of the things that we recognize is that we need a different model for children than we have for adults. And we have historically had one mobile crisis model. But I think when parents are looking for mental health services for their children, they're expecting something very different. We think and tend to respond in terms of diagnosis and medications. Parents don't really think about those things when their children need services. And so when we think about mobile crisis services for children, we need to be able to respond with child-friendly resources. We need to also be able to respond regardless of whether we think it's an emergency or not. And so I think we have to think about those things very, very differently. That also means that we need to look in the community at how we partner with organizations that are trusted in the community that can respond and help us get families to that next level of care. One of the challenges that we often face with young people is because our system requires diagnosis and requires very structured response to children having needs, we by default have a system that really forces children to fail in order to access services. And that's a flawed model. I think that's one of the things that we have to address going forward. We have a very siloed system, over 11,600 youth in foster care. That's up 35% since July of 2012. We have systems that do not adequately share information or partner in providing the best care and support for our children. The other thing I would say about our systems in the way they impact particularly children of color, if you look nationally, about 40% of the kids in the juvenile justice system across the country are Black, and about 45% of the kids in foster care are Black. And that tells us again that we have a not only a siloed system, but a very flawed system, because we have something that's embedded in our system that is disproportionately channeling children of color into the justice system and more and more into out-of-home placements or into foster care settings. We also have a lack of mental health services in schools. We are addressing some of that, which I'll speak to a little later on. But in a given year, 1 in 5 children will experience a mental health disorder. That's about 300,000 children, but only about 75,000 children will receive treatment. When we look at access to care and how we access services in our adult population, we know that only about half the people who need mental health services get mental health services. But when we look at the number of African Americans who need care and get care, it's only about half the rate of white people. And so we have a systemic issue there. And then when we look at what happens with children, many of the children of color who do receive services in situations where oftentimes they may be misdiagnosed. We have a system that tends to respond again to behavior. So oftentimes Black and brown children who may be experiencing PTSD, who may be experiencing depression, get labeled with conduct disorder, ADHD, medicated, and then that cycle just tends to keep repeating itself. We also have unmet health-related social needs. More than 1.2 million cannot find affordable housing. 1 in 28 children under the age of 6 are homeless. And North Carolina has the 8th highest rate of food insecurity in the United States. Greater than 1 in 5 children live in food insecure households, and 45% of North Carolina women have experienced intimate partner violence. And all these things tell us that this was pre-pandemic. So all these things tell us that we have a system that was not working for historically marginalized populations. And if the pandemic did us any service, it was that it really caused us to take a hard look at health disparities and things that were impacting historically marginalized communities disproportionately. Next slide. When we look at behavioral health disparities for Black and Indigenous and people of color, the Agency for Healthcare Research and Quality, AHRQ, in 2017 reported that people of color in the United States are less likely to have access to mental health services, less likely to use community mental health services, more likely to use emergency departments, more likely to receive lower quality care. The African American consumers are diagnosed with psychotic disorders at a rate of up to 4 times higher than white consumers, and that Latinx consumers are diagnosed with psychotic disorders on average approximately 3 times higher than white consumers. Now, even when we're talking about the impact of these health disparities on adults, we have to take into account that the experience of the adult often impacts the experience of the children, because it impacts the experience of adults in terms of how they trust the system and how they engage in the system. When we look statistically, Blacks are about 20% more likely to report psychological stressors than our white counterparts. But yet data shows that we're less likely to initiate treatment and more likely to terminate treatment prematurely. When you look at these disparities for people of color, one of the things that jumps out to me is that when we think about why people of color don't access mental health services, don't initiate treatment, terminate treatment prematurely, part of the challenge that we have had historically is that we don't locate community mental health services in historically marginalized communities. We don't locate them in places that are readily accessible to people of color. So for a lot of our adults that have experienced mental health challenges, they may go years, even decades, before they actually seek treatment. And when they do seek treatment, it is in an emergency or crisis status. That means that for many people of color, and I'll use Black men as an example, for many Black men, their initiation, their introduction to the mental health system is oftentimes in the back of a police car or in an acute care emergency department, because they haven't been able to access services in their local community. And so when they access services, it is when they've reached a point of crisis. And receiving those services via being escorted by law enforcement or just having that initial experience being in an acute care emergency department is not conducive to good mental health outcomes. And it's not going to build a good relationship with the mental health system. So again, for those parents who have children with mental health needs, if they have not seen good outcomes and good experiences for themselves, for other family members, or for their peers, they're not very likely to initiate those services for their children, nor are they very likely to have those services available in communities where they live, work, and play. And so their access, again, even for their children, often turns out to be when they are in a state of crisis. Next slide. When we think about the racial inequity in our justice system, one in 5 Latino and Black households with children are food insufficient. Severe cases of COVID deaths have been disproportionately Black, Latinx, and American Indian. North Carolina counties with a higher percentage of people of color had longer travel times to testing locations. And meanwhile, zip codes with predominant white populations had more testing sites per capita than zip codes with predominantly Black populations. And nationally, access to testing was lower in rural areas, and rural Black Americans were 1.7 times less likely to be in a testing desert than the general rural population. All of these things are important because when we talk about the mental health impact of the pandemic, there's a mental health impact to seeing people who look like you disproportionately die. There's a mental health impact to seeing people who look like you disproportionately have less access to services. So one of the things that we have tried to do here in North Carolina is to let the data inform us in terms of where we need to be placing a lot of our resources, where we need to place our testing resources. We're now in the process of preparing for booster vaccines and for child vaccines. And a lot of what we're doing is trying to focus on making sure that we are leaning into equity by making sure that we provide resources in Black and brown communities for access to the vaccine. Because again, if we don't provide equitable access to mitigate the COVID pandemic, the behavioral health impact of the pandemic is going to be that much more impactful upon those communities. Next slide. So I want to spend this few minutes talking about the behavioral health impact specifically of COVID-19. Next slide. When we look at the pandemic impact, we've seen a threefold increase in reported depression and/or anxiety symptoms. We went up from about 1 in 9 reporting the anxiety or depression in 2019, and in 2020, by mid-2020, we were at about 1 in 3. Younger cohorts, those 18 to 29, report higher prevalence of anxiety and depression, while prevalence among racial groups in that 18 to 29 has been relatively consistent. But national data found from mid-March through mid-October of 2020, the average number of ED visits for child mental health rose by about 44%. For substance use, respondents with children and youth reported an increase in drinks per day, more than 4 times as large on average than a subgroup without children. So again, individuals with children in the household experienced an uptake in drinks per day. Excessive consumption increased more for respondents with children or youth. So again, children are exposed to more alcohol consumption. From July 2019 to July 2020, there was a 40% increase in opioid-related ED visits. That includes adults and children. And according to the CDC, national data in August of 2020 indicated individuals ages 18 to 24 that 1 in 4 has seriously considered suicide in the past 30 days. Next slide. In terms of domestic violence and child abuse, domestic abuse is associated with trauma and negative mental health outcomes. Prior to the pandemic, the CDC reported that approximately 1 in 4 women and 1 in 10 men experienced intimate partner violence during their lifetime, and approximately 1 in 7 children experience abuse or neglect in any given year. Rates of domestic violence tend to increase during periods when families spend more time together. We went through an extensive period of social isolation and the stress associated with the pandemic, which created a situation of increased danger for those at risk of domestic violence. And while we are now loosening many of those restrictions, and you see people moving about more and mingling more, we are still at a point where we don't have the same level of interaction that we did prior to the pandemic. Many of our businesses, and ours included here at the Department of Health and Human Services, are not fully back in the workplace yet. So for individuals who much of their social life was tied to their work and to interacting with coworkers. They've not had access to that. And so that's impacted mental wellness. And when adult mental wellness is impacted, it does impact the mental wellness of children. Even though children are now back in school, we've heard all the rhetoric coming from many different areas. I know we have in North Carolina, I'm sure it's true of other states, where parents are at odds about whether or not children should wear masks in school. And children are hearing all of this. They're seeing the adults yelling and screaming, storming school board meetings, arguing about whether or not children should wear masks in school. And all of this impacts not only the individual well-being of our children, but it also impacts our collective well-being. It impacts the collective mental wellness of us as a society and of our children as a collective group. Next slide. So let's talk a little bit about the path forward. Now, as I shared earlier, in some ways, my lens has shifted a little bit because of the role that I'm in. And part of the reason I say that is because I have always had, as a part of my work, I've always had an equity lens. I have spent the bulk of my career working in the mental health field. And I've always done that with a lens toward equity because I've always acknowledged that people living with mental health challenges, whether it was mental illness or IDD or traumatic brain injury or addictions, people living with mental health challenges, behavioral health challenges are a historically marginalized group because as a group, they're discriminated against in terms of employment, in terms of housing. We even see with our children, once there's a diagnosis attached, they're oftentimes treated differently. And oftentimes opportunities present very differently for children who have a behavioral health diagnosis. So I've always had that lens, but being now in this role of Chief Health Equity Officer, I'm now in a position where I can sit in an equity space with a behavioral health lens as opposed to being the other way around. So now I can look at how our equity efforts, and then as we advance those equity efforts, we can do so with the lens toward making sure that we are also addressing behavioral health needs. Next slide. So I believe that we have to have an equity strategy. Part of the equity strategy for North Carolina did involve standing up the Division of Health Equity. So what we have done here, and as I stated at the beginning of my talk, that I am in the position of being the Chief Health Equity Officer. And part of my role is helping us to develop an equity strategy. That equity strategy involves building and earning trust between historically marginalized communities, behavioral health providers, and funders. It involves working with community partners, community media, and grassroots messaging to educate communities to combat stigma and address concerns about receiving mental health treatment, particularly in historically marginalized communities. Focusing the deployment of state and federal resources to remove or mitigate barriers to accessing treatment in historically marginalized communities. Leveraging the expertise of providers of color who have traditionally served historically marginalized communities, often without access to government grants and contracts. And focusing on justice-involved populations, including our RFAs and RFPs and whatever acronym we attach to putting money out into the community, focusing on those justice-involved populations. Next slide. We also are heavily looking and leaning on implications for telehealth. Telemedicine has the potential to improve accessibility, quality, and patient satisfaction for care in rural, historically underserved populations. But data does suggest that people in need of mental health services from historically marginalized populations, groups like that are Black and Latinx, are utilizing telehealth mental health services and going to follow visits at a lower rate than our white counterparts. And that mirrors a lot of the information, the data that we see on accessing services, period. This is in line with pre-COVID-19 indicators of a lack of cultural competence built into mental health treatment modalities and corresponding disparities in service access. And of course, we need to expand broadband access to many of our rural communities. Next slide. So we have outlined child behavioral health priorities around prevention, intervention, and resilience that we believe will help us to really address many of the needs of children impacted by the COVID pandemic. We'll target trauma as a public health emergency. We will end behavioral health disparities for marginalized populations. I realize these are very lofty goals when we talk about ending behavioral health disparities, but that is our target. We will increase access to needed services, create whole health, whole child solutions, and I should add to that whole family solutions. Build best practices, accountability, and continuous quality. And we'll do that with the systems of care framework. And the pillars to do that will be trauma-informed, resiliency-focused care, and then racial and cultural equity built and woven into our policies and practices. Next slide. So, the foundations of those systems of care, that system of care mentality and how we approach our services means that our services need to be family-driven, youth-guided services. They need to be individualized and strength-based. They need to be cross-system. There needs to be cross-system collaboration. We need service coordination, culturally and linguistically competent services, and evidence-based interventions provided in the family's home or in the community, rather than pulling people out of the community and bringing them into our tertiary facilities. Next slide. So one of the things that we're focusing on is evidence-based outpatient therapy. We're focusing on trauma-focused cognitive behavioral therapy, parent-child interaction therapy, child and parent psychotherapy, and then also utilizing MATCH, which is a modular approach to therapy for children with anxiety, depression, trauma, and conduct problems. And what MATCH does is it really just pulls a lot of the best practices from a lot of the different models we use to really give providers a template for how to provide service and to provide the best quality services for children and families that they interact with. Next slide. Advancing school-based mental health, wellness, and resilience. We're partnering with the Department of Public Instruction and local schools to shape mental health plans to engage managed care organizations and behavioral health service providers, and plans to build youth and family engagement into the practices in our schools. And then also supporting Latinx families in creating mutual help networks within their communities, and developing policy flexibilities that allow for virtual school and community mental health services. You see a lot of that taking place now around the state, and around the country as a result of the pandemic. Some of that has lessened, but we're also looking at how do we continue to weave that into our school system, the same way that we will probably going forward have a hybrid model of how we attend work in the workspace. We need to continue to look at what makes sense in the school system, particularly for children that may still be dealing with some of the mental health impacts of the pandemic. Next slide. High fidelity wraparound intensive care coordination, evidence-based intensive care coordination services. It's appropriate for children and youth ages 3 to 20, most at risk for out-of-home placement or transitioning back to their home community. It pairs the family and youth with family and youth support partners that advocate for the family and youth, promote and teach needed skills, and ensure family and youth voice and choice drive treatment, direction, and development of goals. A facilitator ensures smooth transitions and coordination between services in place, as well as linkage to new services and/or supports. And we are pushing to use high fidelity wraparound services, wrapping services around children and families in the community, as opposed to putting kids in congregate or residential placement where that does not need to happen. Next slide. And then I talked a little bit earlier about child crisis services. We are building more child facility-based crisis services in the state. We've had 2 existing programs. We have 2 more that are scheduled to open later this year. We're also opening a couple of behavioral health urgent care centers. And a couple of them have been done in partnership with the community, where we've had hospitals, county government, and local mental health managed care organizations partner to open behavioral health urgent care centers where people can be treated, triaged. Many of them have, or at least one of them in particular has a lot of both outpatient and inpatient services under one umbrella. And it is a much more effective and efficient means of getting people in and out for services, as opposed to having them sitting in hospital emergency departments. Next slide. And then more evidence-informed suicide prevention strategies. We currently have a 24/7, 365 live person response NC call center for National Suicide Prevention Lifeline. You've heard it mentioned earlier about 988 coming online in 2022. We are fortunate that we already have this one 24/7 call center in the state. We're looking at ways of enhancing that and how we're tying that to 988. Promoting more community training, QPR training, question, persuade, and refer, to really teach people how to help someone who may be suicidal. Counseling on access to lethal means. We partnered with the American Foundation for Suicide Prevention, North Carolina, to provide CALM training, and then providing sources of, and more training on sources of strength for youth and peers. And then we're partnering with the Department of Public Instruction and our local education authorities to implement suicide prevention training. Next slide. And then more trauma-informed community projects. As part of our trauma-informed community project, providers, service systems, and communities, we're using these projects to spread knowledge about trauma and its impact on children and families, examine current practices when interacting with children and families, identify needs for trauma-informed services, create trauma-informed service systems, such as mental health, education, juvenile justice, and child welfare, and then the plan for unified collaboration across systems. The beauty of trauma-informed community projects is that it brings all the individuals together, community stakeholders together, to try to create a system of a trauma-informed response as opposed to doing it in silos. And this is guided by SAMHSA's concept of trauma-informed approach, in which individuals and organizations and systems realize the widespread impact of trauma, recognize the signs and symptoms of trauma, respond by integrating knowledge into policies, practices, and procedures, and then resist re-traumatization. Next slide. And then behavioral health crisis counseling. We've stood up what we call our Hope for NC line. It's a model that we had often used in the past when we had hurricanes on our East Coast. We stand up our Hope for NC line to provide care and a one-stop shop for people to call if they were needing help in response to a hurricane or other natural disaster. We stood it up across the state for people to be able to call in for any needs they may have around mental health challenges with the pandemic. They could also use it just to track resources. Where do I go for information about childcare? If I just need someone to talk to, if I need help with building coping strategies. So we stood up the Hope for NC line. We also set up a Hope for Healers line that was specifically for people who work in childcare, in addition to other first responders. But part of the reason that we did this was because we know that when families are stressed, again, children are impacted by that. There's also a component of this Hope for NC line where we have a texting capability, because we know that for a lot of young people, they would rather text than call. And so we built a component of that, of our behavioral health crisis counseling, to also appeal to young people. Next slide. So we believe that in achieving community resiliency and in responding to the challenges outlined by the COVID pandemic, some of the key overarching principles are we need to learn from the past and the present. So look at the things that have that were these pre-existing challenges that we had, learn from that, look at what's happening with us now, but then we're already now starting to pivot toward what do we do post-COVID in a recovery mode. And so we need to take those lessons so that we don't repeat many of the mistakes of the past. That means that we have to lean intentionally into equity as opposed to perpetuating an inequitable system. We have to develop impactful partnerships. And we have to think about these partnerships in terms of what does partnership look like to the community? What does partnership look like to the families and children? We only learn that by asking them and by letting them inform us, rather than us saying as a system that this is what you need and this is how you need it. We need to listen to the youth and the family voice. And then we need to go big. We're going through Medicaid transformation here in North Carolina now, where we are really doing an overhaul in our Medicaid services. That's a whole presentation for another day. So I won't go into that one right now, but that's a part of our plan. Next slide. Thank you very much. This is the end of my presentation.
Thank you, Victor, for an excellent presentation. Will all of the panelists join us again, please? I know that I have lots of questions, but just to be fair, we did receive questions from the audience, so I guess I'll do those first. Some of the questions I think you guys may have answered. Let me toss this one out. What are examples of barriers to access services for people who are African American and Hispanic? What are specific actions should our behavioral health systems do to address these barriers? Again, I think some of you have answered that, but why don't we, who wants to start?
Yeah, I'm happy to start. I think one of the things I talked about is I think one of the barriers is that we don't have enough resources in communities of color where people live, work, and play. And when people have to, when we think about why people of color don't initiate treatment or are more likely to terminate treatment prematurely, if you don't have resources in the community where you live, if you've got to take 3 buses to get to your first appointment, you are less likely to keep that, to make that initial appointment. And then you are also less likely to continue that treatment for follow-up appointment if you got to repeat that every time you go back to treatment. The other thing I think that is a barrier is we don't have enough providers who look like us. We look around the state and I think, roughly 2% of psychiatrists are Black, 4% of psychologists are Black. And while, as a social worker, and trained clinician, I'm the first to say that I believe a good clinician is a good clinician. And I believe that, a person who is trained in treatment and therapy should be able to treat anyone if they put the effort in to understand the cultural nuances. But I will say this, it is, for me, as a 50-something-year-old Black man, it would be difficult for me to walk into the office of a 20-something-year-old, blonde-haired, blue-eyed female psychiatrist and say, I cry all the time, I don't feel like getting out of bed in the morning, and my sex drive is low. That's a difficult conversation to have, and I'm probably gonna be more reluctant to have that conversation with someone who I don't think understands what that means to me, or the impact that it has on my view of myself in the context of my community and my masculinity. So I think it is a challenge when you look and try to find someone who you think relates to you culturally, and you can't find that.
I agree with what you're saying. Anyone else want to respond to this question? Heather, Jeff?
Hard to follow that. I think that was a great response.
Well, let me add one other thing, because I think one of the other challenges too is that many of the treatment models that we use were developed and based upon the perspectives of white Anglo-Saxon Protestant males, and they weren't, and many of them, the basis of many of our treatment models came from a time when people of color and women were thought of as lesser. And people in the LGBTQ community would have been thought of as mentally ill. And I think that we have to be mindful that we need to develop more treatment modalities that take into account the nuances of race, culture, and ethnicity. And I think we're starting to do that, but I believe that's something else that we really need to lean into.
I totally agree with you. And I think that some of the points you've made get at those myths about eliminating behavioral health disparities that I spoke to. So one was about, we just need to make everyone culturally competent. So of course we need to make everyone try to obtain that goal. But we also, as you're saying, need to have behavioral health clinicians who reflect the populations, the people that they're working with, the communities that they're working with. The same thing about culturally adapting interventions. If you take those interventions that were developed primarily with white males or even white females and try to culturally adapt them for other cultures, that's one way kind of around the barn, but we really need to be developing and putting in significant resources to develop evidence-based practices that come from the communities that they're serving. So I think those are two great points.
So I'm sorry, go ahead.
Oh, no, very quickly, just another thing to add as you both were responding to that is just the importance of working with your credible messengers out there in the community about bringing the messages about services that are available, and notwithstanding the limitations of clinicians who match the characteristics of the population being served. I think that's a really important step. But I do think that I'm thinking about some of the data I shared earlier about some of our EBTs showing some promising evidence of reducing disparate outcomes. That's great information. Put that in the hands of a credible messenger who has credibility in the community, who knows other people in the community who can deliver messages, faith-based communities, other organizations, and I think there's some that can have some positive impacts.
Heather, I was wondering, given what Vic just said, is there anyone, within the technology transfer centers that's trying to take the approach that he described? Or are you working in that arena, as part of your implementation science and research?
And Mary, do you specifically mean engaging mental health providers who come from the populations that they serve? Or are you talking about?
Well, or just, we know that there are lots of evidence-based practices out there that have been around for years. And so I'm just wondering, is anyone really working on taking the perspective that Vic described earlier?
Yeah, I think that, so we're being SAMHSA funded training and TA centers. We don't do the research itself. So I think we really need to be pushing on the National Institute of Mental Health, the National Institute on Drug Abuse, and National Institute on Alcoholism and Alcohol Abuse to fund those kinds of research programs to really, again, build from the populations, up from the populations, those evidence-based practices that are built for them and most relevant to them. We do within our work a lot of, especially with the American Indian and Alaska Native Center and our National Hispanic and Latino Center, do a lot of work to promote evidence-based or practice-based the behavioral health interventions that have come out of those communities. So again, not doing the research on them, but really trying to lift them up. The NED that I mentioned, the National Network to Eliminate Disparities, also each year provides a training series on a number of those culturally relevant and culturally rooted evidence-based practices to really try to disseminate and implement those throughout the United States.
Okay, thank you, Heather. So I have a question for the panel. How can we ensure that we're addressing equity as we establish 988 nationally and building crisis services? How does 988 and crisis services help with equity? Who'd like to start?
I'll start and then would love to hear what my fellow panelists have to say on this. But talking first about the 988, I think it's a great opportunity. I mean, have heard from our communities over and over again that the behavioral health system is fragmented, difficult to understand, and that our families don't know who to call or where to go. And I think that we had this experience in our children's mobile crisis system here in Connecticut. Our old system, when we had 26 providers, each of which had 1-800 numbers, individual 1-800 numbers to access the service. And we found utilization was low and it was not living up to its potential as a service. So as the system was reprocured and redesigned, we went to a single statewide call center operated by 2-in-1 at United Way. Likely that we'll have to think about whether 988 becomes that. But the point is, we saw utilization go through the roof because we made it a lot easier for families to know where to turn when they had a crisis situation. So that I think 988 will play the effect will be similar, I think, for 988. And then in relation to the part of the question around crisis services and how that's going to help with equity, What I often say is, again, the 988 is the entry point. I think mobile response will be a critical role as a handoff from 988 for initial point of contact to the system. But I often say to myself, what are the alternatives if you don't have that? And oftentimes Vic spoke to this, I believe, when he said that the alternatives, the other entry points into the system tend to be through the child welfare foster care or through the juvenile justice system or through the emergency department. No, these are not places we want our children and families to be. So I think the opening up access and information and referral through 988 and looking to our behavioral health crisis responses system as being an alternative to those other bad ways of entering the system will have an important impact.
Yeah, and I think, I think 988 in general is an opportunity for us to reimagine our mental health emergency system in general. And I actually prefer the term mental health emergency as opposed to crisis, because when I think crisis, just has a different connotation. And I think in large part we call it crisis because we don't have the resources that people need when they need them, which makes it a crisis. If we had the resources, it would be routine, but we don't have the resources, it's a crisis, which means it's the system that's in crisis and not necessarily the individual. But I think part of where we have an opportunity with 988 is that we have a system, particularly because it was really built from a law enforcement perspective, we have a system that's really not designed to protect and nurture the person who's having the mental health emergency. We have a system that's designed to protect the rest of us from the person who's having the mental health emergency. It was not designed from the perspective of people, families, and children that are experiencing these mental health challenges. So part of the way I think we build equity into the system is we have to have the voice of lived experience, and not just the voice of mental health lived experience, but the intersectionality, the voice of people who are experiencing mental health challenges while also experiencing racial, ethnic, cultural challenges. There's a difference in being a 35-year-old white man who's having a mental health emergency and being a 35-year-old Black man who's having a mental health emergency. When you look at the disproportionate rate of Black men and Hispanic men who have bad outcomes at the hand of law enforcement, and when you have a law enforcement response, you are creating a perfect storm because you already have a disproportionate outcome in the best of circumstances. Then you bring someone, you put someone in a position where their behavior is going to be irrational, illogical, and the things that you may think you're doing to de-escalate that person only incite that person. You are creating the perfect storm for bad outcomes. So I think bringing that voice of intersectionality to the table is important, and not just in terms of Black and white. There's a difference in being a 35-year-old white man who's living with depression and being a 65-year-old white man who's living with depression. And we need to bring all those voices to the table to talk about how we build that equity into the system, what it means to be a trans person who's experiencing a mental health emergency and having first responders show up. We need all those voices at the table. And that way, I think we can create a system that's designed not only by the people who experience mental health emergencies, but also people who have that lived experience of living in a world that is not equitable from their lens.
Mhm. Excellent points. Let me go to the next question. So from Kenneth Rogers, I find that there is increased reluctance to discuss race-based solutions to many issues, including health, mental health, and children's services at large. Vic, I think this is for you. Could you talk more about how and why North Carolina decided to create a position focusing on health equity?
Yeah, so there are a couple of reasons. I mean, one reason was because the evidence was very clear that the system was inequitable. And I will tell you, when you undertake something like this, it takes buy-in from leadership. That starts with the governor's office when you're talking about the Department of Health and Human Services. So there was a decision with our Secretary Cohen and the governor's office that we were going to look and think differently, look at differently and think differently about how we respond to what we're seeing around some of the the systemic challenges around health disparities, systemic racism that was woven into our system. And as we were in the process of putting together our strategic plan for both where we go as a state in terms of our goals, and then also what we call our North Carolina Healthy 2030 plan, which is our roadmap for the next 10 years for how we build a more healthy North Carolina. It became very evident that you can't really have a strategic plan that raises all of us to a healthier level unless you're able and willing to address the needs of those who are most vulnerable, most impacted. And it really comes from a perspective that you only have health equity when everyone has a fair and just opportunity to live the healthiest life. And in order to do that, you have to be intentional, which means putting emphasis and resources behind addressing that inequity. Because I'm a firm believer that if you are not intentionally leaning into equity, you are perpetuating inequity. We have a system that is already inequitable. Every policy decision that we make either creates and leans into equity or perpetuates the inequity that already exists. So as North Carolina was looking at our strategic plan, we recognized, for one, that you could not in good conscience draft a strategic plan, seeing all what was happening with the pandemic, the disproportionate impact on rural communities, on Black and Brown communities, and not be intentional about addressing that. And we recognized also that we were doing some good things across the department, but when you have a department that is roughly 15,000 teammates, there's a lot of good that's being done across the department, but at the same time, it has no place to live. And so you need a place where that data can live, those resources can live, but we can house an overarching strategy, figure out how do we weave equity into everything that we do across our different departments, build some synergy around equity. And those are really the things that went into to making the decision about creating an Office of Health Equity and creating a senior leadership position that is focused on health equity.
Mary, can I just follow up a quick question to Vic and maybe the panelists on just what Vic said? One of the things that we've discussed at this conference before is that, we've had a lot of discussion on this whole issue of social determinants of health, where everything, like, in some other countries, people have even done research and shown that the taxation system has an incredible effect in terms of disparities, in terms of health and behavioral health. So as we think about health equity, a lot of health seems to be determined by the sort of factors that relate to housing, employment, income, food security, all those factors. So, I think, and this is also a challenge for Heather, in terms of what the mental health technical assistance centers are doing. It's almost like when you talk about equity and addressing equity, you're talking about bringing about social change in sort of like a very massive kind of way to have equity that results in equity through the mental health training technical centers or through health. And so the challenge is, how do you balance the limitations that one has, whether being in a health department or in a mental health training center, to bring about the change that's required for equity? I don't know whether I'm being clear, but it seems to me that the forces for equity are so much larger than just within the health department or a mental health training center.
Yeah, and I totally agree. And I think for us, that was part of the reason that that we felt like from the department level, from the entire Department of Health and Human Services, that there needs to be a leadership position that focuses primarily on health equity, because I think you're right. All of those things impact the health of people. And when I began my talk talking about, even looking at what we've seen in civil unrest over the past year, that has an impact on our health and our health equity. I think where a department has some opportunity, and which is again why I think it's important that it rests at the department level, is that there are things that we have access to in terms of data, in terms of what we measure, and then where we generate, where we put our resources to address the things that we measure. When we are doing contracting with providers or with other vendors, we have not historically looked at how are we making sure that those contracts are equitable, that we are making sure that we are contract with food vendors that represent Black and brown communities, because when we're not putting resources back into those communities. And one of the things that we found early on in the pandemic, when we got ready to address many of the issues that the historically marginalized communities were facing, was that we didn't have credibility in those communities. We didn't have relationships. And so part of what my role is also to build upon those things, to build and forge those trusting relationships in those communities, to go into those communities and actually take the time to listen to communities about what kind of services do you need and how do you need them. And that's much more easily done, I think, from from a leadership level than it is for each individual department to try to figure that out, to your point.
Thank you.
Other responses? Or VJ, any follow-up?
If there's time, I have a follow-up for Heather. I thank you very much for all that information about what SAMHSA is doing with these mental health training technical centers, but I wasn't very clear what they were doing. Are they all sort of moving forward with implementation science to address the issue? Or, is there, I wasn't sure, is there a state that is doing implementation science in this area well? I wasn't very clear about the scope of and the target outcomes of these mental health training technical centers.
Right. So I think in part it's aspirational, and it is in the MHTTC network, especially at our network coordinating office, that is our background and the work that we do. And we're really trying to educate our network about implementation science and how we can best use it, providing education and training to our network and also out to the field about how to use implementation science. So I think there really are some opportunities throughout SAMHSA to look more toward implementation science. Historically, a lot of the training and technical assistance that have been provided, at least through the previous TTCs, was really one-time trainings, workshops, webinars, and we all know that does not work. And so I think there are opportunities to really have a much greater impact in the work that the SAMHSA funded training and TA centers do when they're providing more in-depth intensive technical assistance that maybe doesn't reach quite as many people. We're not, our numbers of trainees is not quite as high, but we're having more of an impact on actual practice change. And there are, each of the SAMHSA funded training and TA centers provides a range of TA services. I'm not saying that they don't already provide those things, but I think that in some ways we would do better to have more of a focus on that.
I actually had that similar question myself, because, just looking at the long list of trainings and materials that have been developed by the centers, it did lead me to wonder, if the centers themselves are evaluating the impact of dissemination and training, or if it doesn't sound like that's a role of the coordinating center, or is
Correct.
it?
That has not been a role that SAMHSA has given us. I think, what's needed, right, is a range, like I said, is a range of training and TA services. So if there's a new evidence-based practice, first you start with awareness raising and that dissemination piece that I mentioned. And then once there's a information out about an evidence-based practice, then you can move to that more specific implementation. And it is at times a struggle, right? Like I'm trying to say with my hands, like it's you have to have a balance between providing services across a state or a region that are going to be helpful for that state or region, and providing more focused, very resource intensive, implementation focused kinds of training and TA activities. So there's got to be some balance across the resource intensity. But I think we could all do a better job using D&I science to inform what we're doing. And SAMHSA could use that as well to inform how they design the training and TA centers that they fund.
Well, I'm hoping that someone will invest some money so that we can look and see if any of this stuff is effective, because again, we know that there's been lots of training and, all kinds of things that have been developed, but we don't necessarily know what the outcomes are. So I'm on that bandwagon too.
Yeah, each of the centers certainly does some evaluation, some limited evaluation. And I think there's movement at SAMHSA to really to increase the focus on evaluation, and also on, I know they're talking about implementation science as well. So we're definitely on that bandwagon.
Jeff, I have a question for you. So you talked about evaluating some of the EBPs and that you saw some impact in terms of disparities with Black and Latino children and adolescents. Which EBTs did you focus on?
Yeah, great question. So those were our center-based, outpatient-based, evidence-based practices. So specifically going to be very similar to Vic, actually, in North Carolina, trauma-focused CBT and our MATCH ADTC program. And we've been engaged in dissemination and implementation of TFCBT for, I think, about 12 years, and MATCH for probably about 8 now, 7 or 8. So we've trained hundreds of clinicians across the state in those models and serve thousands of kids every year in those models. So that's over a 4 or 5 year study period. We had 46,000, which included some who received those evidence-based treatments, but in comparison to those who received other forms of behavioral health care as well, including non-evidence-based treatments or generic EBTs, but not model specific and very protocol driven like TFCBT and MATCH.
Okay, great. Well, I have one more question, and then I guess it'll be time to turn it back over to you, VJ, before we hit the end of this. I have seen some information, just like looking through the internet, where some private sector companies have actually tried to build in incentives to get folks to address health disparities and maybe even behavioral health disparities. And they do that by tying, not only tying into goals and objectives in one's performance review, but they've also tried to tie some money into it. I have not seen what the result has been or if folks have actually followed through, but is anyone doing that in our public behavioral health system, or is it even possible? And here, I guess I'm just, because we know that most of us contract with community providers to provide service. And so that would mean building in some of those incentives in our contracts with providers.
I think it's a great question. I can't wait to hear what others have to say. But when you asked that question, I immediately thought about how we're structuring alternative payment methodology, whether you want to call it that or value-based purchasing. I mean, it's here and it's coming, right? Because many places are already using it, but we're going to see more of it and not less of it over time. So one thing that we're exploring, we have advocated for quite a long time, is when it comes to delivery of evidence-based services in the community, can we incentivize our providers by offering them higher reimbursement rates through Medicaid or, let's not leave our commercial insurance providers out either, because we know that it takes more time in terms of training, competency, data collection, quality improvement activities to deliver an EBP than it does to deliver treatment as usual. So I think we should be looking at ways that we can incorporate metrics in alternative payment methodology, which are structured to improve quality and get better outcomes. Then let's build implementation of EBTs into those rates. So it's just one strategy.
Can we incentivize the some attempt to address these disparities that we've been discussing for this couple of hours?
There are some things that we're building into our Medicaid managed care contracts that addresses some of that builds in incentives for one for much of the I'm losing my terminology now, but there are some things we're building into our payment structure that incentivizes addressing some of the issues toward how you're contracting with vendors, how you're bringing providers into your networks that mirror and look like the communities that they're serving, because we know that we have to somehow incentivize bringing on more minority providers, because it has not happened naturally. So some of that is occurring. Some of it, I think, is probably not as evident, maybe, that it is designed to address inequity. Maybe there's some other things are. There are some things that are put in there to really drive some of the, what we call healthy opportunities, to make sure that people are getting things like transportation needs met, housing needs met, building in incentives for moving people out of congregate settings into community housing. But there are things that address inequities, because many of the people that are currently suffering those things are both the poor, the elderly, and people of color. And so some of those things I am seeing, we are building more of those things into our Medicaid contracts.
Okay, great. Thank you for your responses. I see it's just about time to end. I want to thank everyone on the panel for excellent presentations and for your excellent responses to the questions raised by folks, including us. So thank you very much again. Vijay?
Thanks. I just want to echo Mary's thanks. I think it was a great discussion, and thank you all for taking the time to be part of this panel. I need to give you one piece of information for those of you that are wanting CEUs. The code for this session is NACBHDD-9. Let me repeat that. It's NACBHDD-9. And please include that with the CEU evaluation that we return to Melanie Norwood. Once again, thanks. And one of the things that's going to happen when you get off the Zoom call is you will see on your screen a URL for the evaluation of this session. Excuse me. Please click on that and it'll take you straight to the SurveyMonkey survey. That'll take you less than 5 minutes to complete, but it's very helpful to us in terms of getting feedback for the next conference, as well as for any adjustments we need to make. So thank you all again. And thank you all again to the speakers, and Mary also for doing a great job moderating. And I think it was a splendid session. Thank you. Thank you all. Take care.